we have 3 randomized trials that show that the addition of either ixazomib, elotuzumab, or carfilzomib to lenalidomide dexamethasone improves at least progression-free survival in all 3 trials. What's the role of ixazomib in this setting then, Bill? Is that, would you use that in a younger patient, an older patient, indolent relapse, aggressive relapse? Where's your thinking?
As we know, ixazomib is the oral proteasome inhibitor, the first one of its type approved. The data from the tourmaline study did show a benefit for the 3-drug combination over Len-Dex alone, about a 6-month difference in PFS. The drug combination was well tolerated. I think we aren't sure about when to use this drug though, because I wanted to point out that both this trial and the trial with elotuzumab specifically excluded patients who were on lenalidomide maintenance and progressed. Those were determined to be refractory patients. Now that was not true of the ASPIRE study, which did allow patients who progressed on maintenance lenalidomide to go on the trial. So I think they were different populations, and we don't really know, I think, how true Len-refractory patients would do by adding in ixazomib or adding in elotuzumab.
So I don't know if I got an answer there. When would you use ixazomib?
I would certainly consider ixazomib for a patient who was responding, who had responded to lenalidomide in the past and was then relapsing, and the same goes for elotuzumab.
There are some other, I think the reason people are voting for carfilzomib is the depth of response. Is that important, or is it durability of response, or do they go hand in hand? What do you think?
I think durability is a reflection of depth of response. And I think we are kind of walking around the problem we addressed here before, that for aggressive relapse, you need powerful therapy. For indolent relapse, the question is it good enough to do a less powerful therapy and then sequence to more powerful therapy later? Or is it better to use the more powerful therapy up front? And it's the same question as we addressed in the newly diagnosed setting. Shall you use your best drugs right away? If you say yes to that, then you should ask the question, should you use your best drugs for relapse?
Now you're using carfilzomib, lenalidomide, dexamethasone in the newly diagnosed patient.
Right.
What are you doing at relapse when that disease comes back?
Well, so we would use probably carfilzomib, pomalidomide, dexamethasone. I think that's a very powerful.
What happens if they've had intolerance of carfilzomib, or they don't want to come in every week because of work issues, or they've actually progressed on carfilzomib therapy? What's your alternative then? Well,
I mean, our default would probably be the carfilzomib, pomalidomide, dexamethasone, but we would go over all these options that we have just heard Jatin and Bill talking about here. And I think I have this conversation with my patients. I say that there's the more convenient approach. Patients have been on lenalidomide maintenance for a long time. They almost forgot they have myeloma. And now I show the protein and say it's coming back, and they feel great. They don't want to come back for infusions. So you have basically 2 options. Either you keep on taking tablets, that's the convenient approach, and maybe that works. Or maybe you do a couple of months with infusional therapy, and that's more likely to work. And you have to have that conversation. I think I have that conversation with every patient.
Let me ask, the Endeavour clinical trial didn't use an IMiD, it just used high-dose carfilzomib with dexamethasone. Very impressive results compared to bortezomib, dexamethasone alone. So this was carfilzomib at 56 milligrams per meter squared with dexamethasone. Impressive, no IMiD, so just 2 drugs. What did you think of that, Rafael, and how does that change your?
I think the Endeavour clearly establishes that carfilzomib is a more potent proteasome inhibitor. There are some caveats that need to be discussed. There's a higher dose than it's on label. But the question is, what is the right dose for carfilzomib? We don't know that. It went up to 56 milligrams per meter square. Even amongst patients who had prior exposure to bortezomib, the results of the trial were positive. I think all of what we're discussing are real-world reasons why you may go with one versus another. And I think those real-world reasons are fundamental in how we choose the selection of the different regimens for patients. I'll give you an example. I have a patient who's willing to drive 200 plus miles every week for infusions because he cannot get oncologic care next to his community that comes to see me. Well, that's a person that I'm very fortunate now that I have an oral proteasome inhibitor for induction therapy. And I think we can go in through anecdotes, each one of us, why in specific circumstances each one of those agents is going to be useful. But back to your point, if you just line them up, you look at all the drugs that are currently in the proteasome inhibitor category, there's really no question that carfilzomib is the most potent one.
Jatin?
No, I agree. And I think there's probably just two things I just want to quickly comment on. And number one is that when we think about the right dose and schedule of carfilzomib, I think probably what I've thought about is that carfilzomib 56 is full dose therapy and not high dose therapy, because I think that's a misnomer. I think that's full dose therapy. And then you dose attenuate if you're combining it with something else, like we do with everything else. Or if you're going to do it in later lines of therapies, you dose attenuate. So you start off with a full dose in the relapse setting as a doublet of 56. If you combine it, which we often do with len or pom, then you need to dose reduce, as opposed to saying that 27 is full dose and that is high dose. I think that, to me, is a different way of thinking about it.
Yeah. Just, you know, but economically, if particularly at the US, this might be quite useful, right, to just be able to give carfilzomib with steroids without another drug.
Exactly. So I think that does open up options for patients who are, for example, len refractory. That, carfilzomib dex, based on that Endeavor data, I think is rather powerful data as well.
Panabinostat, folks, what do you think of that? We have another positive phase 3 trial with Panorama with panabinostat bortezomib versus bortezomib alone. Bill?
Yeah, panabinostat is another oral drug, and the trial that showed benefit unfortunately paired it with a parenteral drug, bortezomib, so you had to use it. You have one oral drug, but you're still having to give shots to a patient. It did show benefit. The drug may not be optimally dosed in that study. There was a fair amount of GI toxicity, and I've heard of regimens where instead of giving the drug every week, you give it every other week. It seems to be better tolerated. I think we need to learn more about how to use that drug, but I think it does have benefit in the right patient population.
Jatin, didn't you have an RVD vorinostat, panabinostat?
Panabinostat. So we have a fair amount of experience at MD Anderson with panabinostat. So I think what I'd highlight here is coming back to what I said about transplant. Until you can cure the disease, use every therapeutic option. So though we're excited about some of these novel therapies, panabinostat is still an active drug. And so make sure you don't forget about that for our community physicians, that it's still an active drug, and for an incurable disease, it's an important option for patients.
You use sub-Q bortezomib with it?
Yeah, so that's a great question. So I think that the phase 3 trial did show actually a pretty impressive hazard ratio for patients who had a prior IMiD and a proteasome inhibitor. The progression-free survival improved from 4 months to 12 months. So it's actually a significant improvement in that subset of patients. What we've done now is 2 trials with panabinostat. One, we did RVD plus panabinostat up front. I think that was important, again, just speaking to the oncologic principles, that we're able to get a high depth of response with 50% of our patients getting a CR after 4 months. And that's consistent with what we've seen with panabinostat globally, that when you combine it with other proteasome inhibitors and IMiDs, you improve the depth of response. And number 2, we've combined it with carfilzomib. And importantly, and I think Ajay Chari combined it with lenalidomide. And it's very different when you combine those with carfilzomib and lenalidomide, that 20% plus grade 3 and 4 GI toxicity essentially resolves. And so we actually see almost no grade 3 and 4 GI toxicity or cytopenias that we see when we combine it with the bortezomib. So I think the partner drug consistently now, when you combine it with Ajay Chari's experience as well as our experience.
And he's at, Dr. Chari is at Mount Sinai.
He's out at Mount Sinai. And Jesus Berdeja from Sarah Cannon also combined it with carfilzomib, very similar experience. So I think globally we're seeing now multiple data sets that when you combine panabinostat with carfilzomib or lenalidomide, actually it's a kind of active combination that's well tolerated, very different than what we see with a Panorama when you combine it with weekly.
Other experiences with panabinostat?
We are not using it a whole lot right now, but I think those data are interesting, and I agree, of course, with Jatin that until we have a cure, we need every drug.
All right, let's move on to the fun new stuff.